So I'm Brian Touhey, Pharm.D. I graduated URI in 2009. I'm from Albany, New York, which is upstate. And when I graduated, I went back there to be close to my family at home. I started out in the retail environment working for CVS. From there, I stuck with retail. I stayed with CVS for about 9 years as an intern and pharmacist. After that, went to ShopRite, which is a local grocery store chain here. After that, did a year at an independent pharmacy, which did a lot of long-term care. After that, ended up at medical marijuana dispensary, was the general manager there for about a year and a half. And then ended up at Quorum, which is a division of CVS, does home IV medications. And then about 2 weeks ago, started at the New York State Department of Health, working with primarily they're working on going away from managed care for billing Medicaid recipients and going back to a fee-for-service format. So there's some assistance there with formulary management, with clinical decisions and things like that. So that's where I am now. I apologize. I can't remember the other. Let me see if I can pull up the other. Let's see. Oh, so in terms of why I chose URI, so there actually is there's a school here in Albany College of Pharmacy, and there was Rhode Island as well. And ACP, it was probably about a 10-minute drive from my house. And Rhode Island was about a little over 3 hours. But I think the thing that was the deciding factor for me was just the variety of people and the choices that you have at Rhode Island. When I toured ACP, and this is nothing against them, but they were like, oh, you're in with all pharmacy students and you can all study together, which is great, and you're all learning at the same pace. But there's something about having people from all walks of life and people with different learning disciplines. And some of my best friends at URI ended up being kinesiology majors, English majors. And so I think that the variety there and the dean at the time, Dean Lozier, is she still there?
Don't believe so.
No. Okay. Yeah. I remember when I was in high school and I went to Rhode Island and toured it, and she, the way she spoke about the experience there was one of the deciding factors for me, and just having that variety and the different people there. I think I learned a lot in class, but then you're also able to learn a lot outside of that from the people and the relationships that you forged. So and I ultimately, if I had to make the decision again, I'd make it every day of the week. Yeah, I absolutely loved URI, and yeah, I think the experience was fantastic.
Right. And I can kind of second that almost, because you have your kind of class of pharmacy students, and it is like a close, kind of tight-knit, small class, but that's just kind of within the campus of all of URI, which is really cool because obviously there are all types of people, super easy to kind of get involved with things and meet new people. So
yeah,
it's nice to kind of have a diversity in kind of the people you meet and become friends with ultimately.
Yeah, I think there's something to be said about that, and feeling a part of a bigger community,
Right.
Not just in the pharmacy school, feeling a part of that, but then just across campus, having this this galvanized feeling with everyone is, yeah, I loved it.
Right.
Awesome.
So I guess as far as your like career path up to this point, you've been involved with a lot of different things. So I'm just wondering maybe what positions that you've had that have maybe that you've enjoyed more than others, maybe reasons why certain things were more interesting or more kind of rewarding for you.
Yeah, I'll start. I think as my career has gone on, I think the more rewarding I feel, and not to say when I was young it didn't feel that way, but as the years go on, you gain more perspective on things. That's just the way it goes. And when I first graduated, it was about 3 months before I became a manager, which I was incredibly proud of, managing a CVS. It ended up, being really challenging, and I did it for about 2.5 years. So I'm really proud of how I hung in and did it, being so young and still leading people that were older than me that saw me as their peer rather than just some young guy coming in. So that started me off on a note that I could hang my hat on. More recently, I would probably say the interesting one, and the one that a lot of people get engaged about is the medical marijuana dispensary. Per New York State law, a pharmacist is required to be at the dispensary at all times. And the company that I worked for, they basically made it a 2-for-1, where, all right, if you have to be there the whole time, you're going to be the general manager as well. And it took me a little while. It took me probably about 3 to 6 months, probably 3 months to get used to THC and CBD, and then 6 months to really kind of master it and learn its therapeutic nature, specific to dosing and ratios. And I think that might be actually the setting in which I'm most proud. Basically, I went into that general manager position, and within the first week of being there, all of the employees unionized, and we ended up potentially getting bought out by another company and having to work under them. And the management above me was like, well, you figure it out. You have to hire your own people. You have to set the hours. As you can imagine, there's a lot of safety and security that goes into a job like that. It was an all cash business. So we had a lot of cash on hand, a lot of product on hand, which was essentially controlled substances that weren't federally regulated, but that were approved by the state. With that, obviously the Department of Health would keep a watchful eye on things and make sure that your products were appropriate. Basically, you had THC and CBD, and you had to dispense those in certain ratios. Some products were high CBD, some products were high THC, some were a mixed bag. We could do inhaled products, oral products. Couldn't do any topicals at the time. So, and everybody came in with different, there were 13 qualifying conditions. So somebody had to meet certain criteria from a doctor and get certified before they came in. A lot of times, I think it was 71%, right around 71% was chronic pain. Obviously looking for an alternative to opioids. And I feel like I was there at the time when the opioid crisis was really being noted by the CDC and other government agencies. So with no alternatives, then medical cannabis came in New York State, and the patients that I would speak to, they were very receptive to it. The biggest factor was probably cost. Insurances didn't cover it, so it was a lot of out-of-pocket expense, particularly for those who were on Medicare, Medicaid, and did not have the income to continue the therapy, at least as the way we wanted them to. So that part was a big reason for discontinuation of the therapy. But overall, it was really rewarding. I got to hire my own staff from the ground up. We started a home delivery service in which I was involved with writing the SOPs, standard operating procedures for those, and executing those. And with home delivery, the delivery vehicle actually had security features in it to prevent theft and to keep the couriers safe on the road. And it was a nice service that we rolled out, because if you're in pain and you're disabled, having it come right to your door is a nice option. The medical cannabis industry was on the forefront of a lot of things, and I feel like I was exposed to the business a little bit. I was exposed more importantly to the therapeutic nature of it, and seeing people get better, I think was just the most rewarding thing, because it was old school in a sense where you had to pick somebody's regimen. Basically, when a doctor certified a patient, they would just come to us, and the doctor would usually leave the certification open and say, all right, now you figure this out. And new patients coming in, pharmacists were required by law to consult with every new patient that came in and to oversee the regimen going forward. So the clinical management was a little different, because there was no blood work, there's no scans, there's nothing like that. We go based off of how a patient feels or how they respond, and to see people get better was just amazing, because you did see it. And if they were able to continue it based on the cost, then the sky's the limit for some of those patients. So with the way I had to manage the culture of it, I will say there is a wonderful culture around cannabis, just this feeling of wellness, where you feel better and you're able to enjoy yourself more. And I'll be honest, coming from where we come from, where we're more clinician based, sometimes we're not as involved in certain cultures, but to be involved in the cannabis culture, and some of our staff were great advocates for the patients, and saw things coming down the line, whether it was a certain type of plant or a certain delivery system of medication, that there was always something coming out, whether it was legal and regulatory or scientific, that was, yeah, it just kept the conversation fresh and exciting. So that's probably the setting that I was most proud of. When I went to Quorum, I was that particularly as well. I feel like, not having been accustomed to IV meds since basically I was at URI, and adjusting to that, I feel proud of that. I was on a special project at Quorum in terms of the IV medications, where I was on the TPN team. So I would work exclusively with a lot of GI providers or surgeons. We serviced the New York City area, and a lot of those doctors didn't have a lot of time, and their time was very precious. So I would learn to cater to them. Usually we'd have weekly lab draws, and so I would have a spreadsheet of all their patients, all their Chem 7s, and some other lab data that they were looking for, and sometimes in the exact order that they wanted those labs read off to them, and then they would adjust the TPN. For instance, if somebody's potassium was 3.3, they'd be like, all right, how much potassium are they on? Let's up the KCL to whatever it would be, and it might be a minute of that doctor's time, and then there would be probably 4 hours of work after that to put in the order and get another pharmacist to check it per the policy, and that part, to me, they actually working especially on TPN. Some of the doctors provided really good feedback on what we did, because we would just work specifically on TPN. At Quorum, there were, of course, other IV medications, Vancos and what have you, that required clinical monitoring. Once or twice a week, blood draws for Vanco patients, depending on their kidney function. Quorum had a nice backbone of policies where if you weren't sure on what to do, there was always a policy there for you to read up on, and including in TPN and other antibiotics. And I feel like they provided a strong base on which you make clinical decisions. And not having been in that environment for a decade, and going back and doing as well as I did, and having positive provider and patient feedback, I feel was a point of pride as well. With this new job at the DOH, I will say it's my second week now, so I'm still in the training and onboarding process. There's still a lot of paperwork to go through, but I feel like over time it's going to be very rewarding. It's always been something in the back of my mind, because working the retail setting at CVS and ShopRite, it was always great to help a patient. You know, if it was a over-the-counter recommendation that you just absolutely nailed for them, they came back a couple days later, said their symptoms are better, or if you stopped a drug from going out the door because of an interaction, different things like that were really rewarding. I think at the Department of Health, you get to help patients on a macro level. And that to me was always something that I was interested in. And with a retail background, it does help the Department of Health with what pharmacies are billing, particularly when they bill Medicaid for prescriptions. And if they're able to see paid claims or prior authorizations, things like that. So the retail background, hopefully I can be of service and provide some nice insight going forward for the DOH.
Right. Yeah, I feel like it's kind of unique to be able to have so much experience in a lot of kind of different niches,
Yeah.
which I could definitely see being kind of valuable when it comes to potentially, I don't know, I guess like deciding how maybe like policies are implemented in the future, all things like
Yeah.
that.
Yeah. And they did say at the DOH, the one unexplored territory for them is home IV meds. They said it's been something that they've wanted to tackle for a while, to control costs. Obviously, every year they go up against a really tough budget in New York State for the DOH, and I think with my with what I know with IV meds, maybe I can provide some insight there too as to what can control cost, whether it be just divvying up meds by what preferred, non-preferred, or maybe there's an age restriction or some other therapeutic restriction that we should put in place or not put in place depending on what the clinical information shows. So I think having that jack of all trades will help me with the DOH and what they're looking for in a pharmacist.
Right. As an infusion pharmacist, would you say most of the work you did was like clinical in kind of deciding how patients would be treated, or kind of looking at lab values, talking to doctors, or was there also, I don't want to say, like, was there also kind of an administrative part to it, like dealing with insurance, kind of similarly to how retail would be done, or would that not be as much of like the pharmacist's role?
It was a little bit of insurance, but it wasn't a lot. A lot of times there was a billing team that we would submit to, but if there was a med that we had questions on, like daptomycin is really expensive, and we would say, hey, can you run a workflow on this patient for daptomycin? With working with home infusion, it was also interesting because you take by mouth for granted. You just take it for granted. Whereas with home infusion, you have to make sure that if they have a PICC line in place, that the tip of the PICC line terminates in the proper spot for potassium and other things that can be corrosive to the veins. Make sure it has proper blood flow. And sometimes those lines can clog up. The alteplase therapy, TPA, I think it runs about $200 a vial, and some insurances don't cover that. So if a patient ends up, like if a nurse goes to draw labs or check the patency of the line, and they see that the line is potentially occluded, we can try to run insurance on that or send it to the auth team. If it's not covered, then they have to go to the hospital to get the line looked at. So it wasn't as much of insurance, which can be both good and bad, because you do kind of want to see how the sausage is made, so to speak, when billing these claims. But it did allow us to be more clinical in nature. It allowed us to trend someone's creatinine if they're on vancomycin, make sure it doesn't jump up. It allowed for, particularly on TPN, to trend their electrolytes and their magnesium and phos. Do they have enough of these, as well as solubility of a TPN admixture. So the calcium and phos can precipitate. So if one needs to be increased, making sure that it's not going to precipitate out when it goes into the mix room. So it was definitely more clinical in nature, talking to these providers, and a lot of times with those providers being so busy, having some of the knowing what questions they're going to ask and having the answers to them. Like if, for example, potassium infusion rate, you can't infuse potassium too quickly. If they want to up the K rate, make sure that they know what the ceiling is. And then also coordinating with the nursing team if the doctor wants a lab draw stat at home, or if they need to go to check, make sure that the line's flowing properly, things like that. So it was definitely more clinical in nature, and different things to think about that I wouldn't have normally even thought of. Not even just the meds in the retail environment, but you're also talking about with the line being in place, you're talking about human anatomy and the pH level of drugs and solubility, compatibility in D5 or normal saline, different things like that. So really got you thinking in a totally different and predominantly clinical way.
Right. Yeah, because my clinical experience is mostly just within like a hospital setting. And I have enjoyed like the clinical kind of scenarios that I've been in, and like the way pharmacists can kind of intervene or kind of just provide value in general for patient care. So it's cool to see that. It's also true for infusion. I feel like infusion pharmacy is maybe underrepresented, might be the word, in terms of just kind of how much people know about it.
Yeah.
But I've always found it interesting, like kind of the different puzzles that every different patient kind of presents as. So it's cool that pharmacists are also involved in that role, and it's kind of unique in its own way.
It is, yeah, and it's pretty similar to hospital. The couple of things that stick out in my mind, the difference is there is more of looking at stability. I know in the hospital, and I've talked to hospital physicians that there may be a drug with only 2 days of stability, and sometimes it was a challenge at Quorum because maybe we couldn't ship every 2 days to someone's house, and they're like, why can't you get it done? But then as time went on, you got more creative as to maybe I pick a different drug, or maybe I pick a different diluent to use it in that can be compatible. And then also, with the IV line itself, I've had issues where if it falls out of place, or maybe the tip of the line didn't confirm to be in a spot suitable for being at home. And in those cases, it's kind of like, all right, clinically, I cannot manage you until you go back to the hospital, get everything sorted out, and then you can come back home. Had that happen a couple of times. For instance, there was one patient, she had breast cancer, and it actually metastasized, and they tried to put the PICC line in, and they couldn't get past a certain tumor to get the tip into the superior vena cava, and they just kind of left it there. We had to unfortunately send her back to the hospital. What we did was we ended up, she was on TPN, we ended up doing it peripherally, actually. And at that point, you have to worry about dextrose content because you can't do too much dextrose peripherally. So you may answer one question and then it leads you to another subset of questions, that particularly for home care, you always have to think about that, as well as maybe in the hospital, there can be a fix for it quickly. If they're at home, you have to think about the potential for keeping someone safe in case complications arise and they don't have access to something immediately. They have pretty similar otherwise to hospital with those other factors in. And I think it really started to take off when COVID hit, because when I first started, COVID wasn't fully pronounced when I first started with Quorum, and then all of a sudden you just saw this big rush, and I think doctors really wanted to get patients out of hospitals is any way that they could. And the referral piece or the intake piece that we had was making sure we had all the clinical information before they started. What's the diagnosis code? Do we have cultures? Do we have a MAR saying that they were on this med, or do we have to send like an anaphylaxis kit to the house with them? So yeah, a lot of different flags kind of ping off in your head that it sometimes wasn't a straightforward answer, but those things always kept it really interesting, and you always saw something fascinating each day, some sort of unique situation where maybe a patient wasn't suitable for home care, or maybe they had a type of infection that you hadn't seen before, or were on a med that if it was your first time dispensing it, you'd look up the policy and see exactly how it was done. So yeah, there are a lot of unique situations. Even in my bubble, just when I would just heavily focus on TPN, we would still get patients on Vanco and Dapto and everything else. And yeah, I would still refer to policies a couple times a week. Just not even regarding TPN, just on other IV meds that we go with. So always kept things interesting.
Right. I do want to find out a little bit more about your role in the kind of medical marijuana dispensary. So a question I have, well, I'll start by saying I didn't realize that pharmacists were like a required aspect of the dispensaries in New York. So I was wondering, just kind of as a pharmacist in that setting, the kind of responsibilities you had. I know you've mentioned you're also the manager, which adds its own other slew of things. But I guess just like as a pharmacist, the kind of maybe more clinical responsibilities you might have had while you were there.
Okay. Yeah. I mean, it was the alarm company had my cell phone. So if a moth went by I would get a call at 4 a.m. sometimes. But other than that, in terms of the clinical nature, we really didn't have much to go off of. There was a wonderful book called Cannabis Pharmacy, I believe it was. I might have it. I don't think I have it here. Hang on one sec. Let me see if I got it.
All right.
Yeah. It's backwards for you, but Cannabis Pharmacy, it's by Michael Backus, Backes, and it wasn't the end all be all, but it would digest pieces of literature from Israel. Interestingly enough, had some studies. Europe, of course, is ahead of us in this game, but there really wasn't a lot of literature. And I would tell patients this. So as I said, we were required to meet with every single patient if they were new. And then if they were getting refills, we weren't necessarily required to, but if they requested us, or if we wanted to check in on them for any reason, we would sit with them and have a discussion. And I would tell them that your response is as important as some of the pieces of literature that we find, because without anything there, you're basically a case study in and of yourself. And so your feedback, good or bad, is valuable to us. My daily operations, I would come in, and there obviously were multiple security checkpoints, security cameras. If even one went down, we had to write an incident report and send it off to the state. If power went down, we had to shut the whole thing down, tell our compliance team. So you go through, your security doors. In the back vault was where all the product and all the cash would be. And you take inventory every morning, take inventory every night. If anything was off, even by, one bottle of capsules or anything like that, you would have to stay until you figured the whole thing out. And sometimes it took hours, but you had to make sure your reports look good at the end of the day for submitting to the state. As pharmacists, we were required to run the prescription monitoring program. Are you familiar with that controlled substance monitoring program? Each state's a little different with it. New York State has their own. I believe some actually have interstate ones. We call it the PMP, prescription monitoring program, but basically pulls up a patient's entire controlled substance history. So before we dispensed any medical marijuana to them, we would have to pull up their prescription monitoring program. A lot of times, medical cannabis didn't have many interactions, particularly with opioids or anything like that. So we would pull it up, and if we saw, mainly what we would look for is, did they go to other dispensaries? What did they get? Are they exceeding their 30-day supply in that regard? Maybe they went to the dispensary down the road and got a bunch of vape cartridges 3 days ago, and that may produce me walking out to them being like, hey, what's going on? You know, we can't really sell to you today, I'm sorry. But in terms of opioids, benzodiazepines, other things like that, we would look at it. The reasons that I would track it to see if actually somebody was weaning off their opioid, which was the case. It was tough. Everybody with chronic pain obviously was different. Some people, their ultimate goal was to get off opioids. Some people, their doctor put them on as many milligrams as they were comfortable with, but the patient wasn't comfortable with that. So the patient needed extra relief. So that's where we would come in and try and provide as much extra relief as we could. So you would still see maybe the doses wouldn't change on their opioids, but you wouldn't get discouraged by that. Maybe that was part of the plan. So everybody was a little bit different in that regard too. We would run PMP on everybody. And then at the end of the day, all of our data of, we would, if somebody got, 3 high THC vape cartridges and a bottle of high CBD capsules, each had its own NDC in our system. And we would submit that data to the state each night. We would have a file converter that we would submit off to the state so that they knew what a person was getting that day, what we sold to them. The management piece, obviously, running morning meetings and things like that. But the clinical stuff is really where, it was fascinating. And we always had an answer, which was good. We didn't have to say, oh, you have to call your doctor. That part was awesome to me too. And I would tell that to every patient. I would say, give me a call. We never run out of answers here. Whereas in other settings, maybe there is some of that. So that part was great.
Right. Yeah, it's interesting to see just how much goes into the whole kind of process. It'll be interesting to see kind of how things go from here, because I know obviously we've been kind of historically limited in our research, so to speak. So it'll be interesting to see in the future. I'm sure it'll play a bigger role in the future, I tend to think.
Yeah, I hope so. And I think everything with COVID kind of slowed down the progress a little bit. But I'm hoping it gets back, because we really did. And even in the dispensary itself, I feel like we made progress with seeing people get better. As the dispensary grew in business, I actually was able to hire another pharmacist. And together we created what we called the Cannabis Collaborative. So we used Google spreadsheets and Google Hangouts and all that for our in-house communication system. And we would actually use it to follow up on unique patient cases, or to just make footnotes about certain disease states. And we couldn't really share it with anybody. And that part was unfortunate. We shared it with our other dispensaries in Syracuse and Buffalo and down in the Bronx, but yeah, if there is anything going on, there's no monitoring of people getting better. And the federal regulation is still what it is. So all these states are on an island to figure it out themselves. Some of these states don't require a pharmacist to be in the dispensary. Illinois, the company that I worked for was based out of Illinois, and they were that way. So it's almost like you get a prescription from your doctor and you go somewhere to try it out, and there's not a licensed professional in the building. There are people experienced, but they're not licensed, and they make a recommendation. You go home, you try it, it doesn't work, what do you do? And I think that the fact that we're in that building, I hope that stays that way, because I think the state sees the value of doing that. And we do, my old partner and I, we would work very closely with certain providers as well. The tricky part there obviously is, no steering, make sure that there's fair play and everything like that. But working with providers was really rewarding. One of the providers I worked with, he's from Belgium, and he would actually go to conferences. This is before COVID hit, but he would go around the country, and then he would go actually over to Europe, and he would send me pretty interesting articles. I can't remember what it was on. It was a neuropsychiatric disorder that one of his patients had, but I feel like we're behind the times, and we could be doing a lot better for our patients. A lot of them, obviously, that I talked to were worried about the coverage and the cost, and that part's going to be tough. Going back to everybody's 30-day supply, what do you do? Do you cover 4 vape cartridges a month, just based on the plan? Do you do like a prior authorization system with providers going forward? The New York State actually did propose something when I was a manager, or one of the legislators did, but it pretty much got shot down the moment it was discussed because it's not federally regulated. So their concern is either A, they won't get funding for it, or B, maybe the feds cut their funding in other avenues that they just don't want to risk that. So I get it. I get that part of it. But I think once the feds come through with at least something saying that we can study more of this, we are really heavily relying on what our patients tell us. It was good being there just to hear their stories, the befores and afters, and to walk them through the process. Even though I left it there because as you saw my daughter going to bath time behind me, it got to be basically a 24/7 operation. And for family reasons, that's why I decided to go to Quorum. But I actually still keep in touch with those guys. Some of the doctors actually, one of the doctors didn't even know I left and still texted me about certain clinical information that he found. And I'm a huge advocate for it. Even having left it, I do miss being in that environment, seeing people get better, especially on regimens that you crafted yourself. You put your name on it, and seeing these individuals who went from wheelchairs to walkers to a cane, leaving your dispensary doors was really cool. We're at the tip of the iceberg, and I don't think we're going to get any further within the next half decade, but I hope I'm wrong. I really do.
It's all very interesting, and looking forward to see what kind of comes of it. Yeah. I think that was most of the questions that I wanted to get to. I guess before we kind of wrap up, is there anything else that you kind of want to just say about pharmacy as a career in general, or anything that you'd want to impart upon someone who might be thinking about pursuing pharmacy, or maybe is thinking about like URI as a destination for pharmacy school?
Yeah. I think I'm a good example of you can make of the PharmD what you want. You're never pigeonholed, and what you have to do is take your experiences and just relate them to what you want to do. And when I was at Quorum with IV Meds, like I had mentioned, it was over a decade before I had been a part of that, but it can come back to you. Some of that training actually came back to me, some of those lessons that I learned at URI, and just being able to relate life lessons and lessons in your career to what you want to do going forward. And what you want to do now might change in a couple of years, and that's fine. Your goals don't have to just be permanent. Same goes for work-life balance. When I started, my work-life balance was different than it is now, and it's okay if that changes. Every 3-4 years, just check in with yourself and make sure that your work-life balance is where you want it to be. And it's okay if the balance tips towards work. That's fine, especially if you're doing what you want to do. And if you're not doing what you want to do, it's still okay. Just know that it's not sustainable, and maybe you won't feel fulfilled at the end of the day, but persevere and continue the hard work, because to get to where you are, particularly Mike, you know how much you've sacrificed to get to where you are. That type of mindset doesn't go away. And if you keep that frame of mind, you will persevere and get the path that you want. Yeah, just continue the hard work and continue the virtues of what it is to be a good pharmacist, of being a good person, being approachable, having good communication skills, having sharp knowledge, knowing where to go for answers if you don't know. Those are things that stick with you from your infancy as a student. So that to me, one of the biggest things over my time, the work-life balance, how it changes it, and how your goals can change. And maybe working for the DOH ultimately was a goal of mine. Maybe it is where I stay, maybe it's not, but knowing that you don't have to be in a permanent situation. Use your pharmacy degree as an opportunity to do what you want to do. And maybe if your work balance is overloaded, just don't forget that the difference that you're making in people's lives. Sometimes that gets lost. I know working at a 24-hour CVS or managing the CVS that I did, sometimes you go home at the end of the night and you feel almost let down or ashamed of getting yelled at or not satisfying people. Just don't forget about the difference that you're making in people's lives, even if they don't see it. You've been trained to make that difference, and keep that in mind. So that would probably be the one thing I would say. I think Rhode Island prepared me well for that, because the workload was really challenging, and there were, and I'm sure you've had to sacrifice some things in life. We can't always have fun. We can't always do what we want to do, but it taught me we have to do what we have to do to get to the next step, to graduate and to have a successful and fulfilling career. And Rhode Island, I think, kept me in line with that. There was the faculty there was outstanding. Dr. Estes, as you know, Dean Lozier. It felt, at the time that I was there, it was 90 students. So it was really a smaller, close-knit environment. And I think even though it's larger now, I imagine it's the exact same way. The University of Rhode Island, from what I saw when I was looking at schools, was a top-notch pharmacy school. And I I'm very proud of where it is today too. And I'm proud that I graduated from there, because I think it continues to have such a high reputation across the country, and for good reason. I think it prepared me clinically. I think that they're going back to the variety of students on campus. It actually helps you with your communication skills in a way, because as a pharmacist, you have to digest information from providers and talk to patients about it. You're that go-between. You're the person who can be approachable at any time of day and be able to take that medical jargon and make sure that a patient has full grasp of their medications before they walk out that door. And I think that sets Rhode Island apart too. I feel like I really honed in my communication skills at the school, and that prepared me for being in management, where I was a couple different times, and it also prepared me for interviewing as well for these jobs that I wanted. So I think, both clinically and as with pharmacotherapeutics and in other avenues that maybe other pharmacy schools don't think about, I think that's what Rhode Island excelled at. And the experience overall, I wouldn't trade it for anything. And clearly, I think that looking back, I wouldn't undo a single thing that I did in choosing Rhode Island and choosing the path that I did.
Right. Yeah, I will say that a lot of the things you mentioned that were true when you were there, I also relate to, which is good. Definitely like a good community.
Yeah.
You have a lot of kind of assistance with either like faculty or just your peers along the way, and
Yeah.
you really feel like you're not doing anything like by yourself, which is nice.
Yeah. Yeah. That is nice. And, obviously living off campus near the coast is nice. I will say there wasn't much time to enjoy it, but that was kind of a good thing, because the temptation was always there. But where we were, you had to exercise discipline. And, maybe I would, drive to the beach or walk to it just to, maybe clear my head for 10 minutes while I was studying. But I think the faculty there also prepared you for that discipline. Hey, look, there are students with other specialties on campus. There's a beach, 15-minute drive away from campus. But the fact that they're able to put out such quality students, such dedicated students that go on to be successful, I think it speaks to their cultivation of young pharmacy students and how they can maintain that discipline through and through. And it is a big, beautiful campus, and the whole experience was beautiful. Yeah, it was awesome.